Alana, I think, let's see, no, you have permission. Yeah, you're good. You are all set. All right, well, I have 10:31, so we will get started this morning. One quick thing with regard to the study guide for diabetes. If you haven't seen the updated study guide, I removed the last required reading. That was from a textbook that you do not have this semester. And additionally, I have not changed. I just found out yet last evening that the pages for the pediatrics text, the Ricci text, were incorrect. I had not had the most recent edition, so I just want to let you know that the pages for the Ricci text that are required are pages 1797 to 1808. And it's the pediatric content on diabetes. Okay. All right. Everybody.
Could you say those page numbers again, please?
I will, yes.
Thank you.
1797 to 1808.
Thank you.
Sure. All right, so diabetes. Before I want to share a screen with you, so let me just do that first. All right. Diabetes is a content area that I really want all of you to become very comfortable with, because I feel strongly that none of you will enter a field in nursing where you won't have to have a solid handle on management of diabetes patients, whether it's pediatrics, maternity, med-surg, whether you're in an ICU or any unit, certainly the emergency room, in community health settings and occupational health settings. No matter where you go, you are going to encounter patients with diabetes who are going to need nursing assistance with management of their care. So I feel it's really, really important with regard to your nursing education that you really get a good handle on this content. So please ask questions as I'm going along. And if anything comes up from your reading that you have questions with, make sure that over the next 2 lectures, we talk about those, because I want to make sure that, that you're getting what you need to be effective nurses, and of course to pass your nursing boards as well. All right. So diabetes is a group of metabolic disorders that's characterized by hyperglycemia, which is an increased level of glucose in the blood. That increase in glucose is a result of one of 2 things or a combination of things. It's either a result of inadequate amounts of insulin, so where there's a defect in secretion or production of insulin, or there is a problem with the insulin action, or both. So there may be the insulin action could be being blocked. That is, we consider that insulin resistance. There's enough insulin circulating in the blood, but the tissues, the cells aren't using that insulin effectively because there is resistance to that insulin. So sometimes the person is making adequate insulin, but it's not being used well. They're making inadequate insulin, and additionally, it's not being used well. Or in some patients, they don't make any insulin at all. And we're going to talk about which type of patient fits into any of those categories. We talk a lot about hyperglycemia in diabetes, and that certainly is a problem. And we also will be talking about hypoglycemia. Both of those are short-term problems and are certainly significant. But the real issue with diabetes is, over time, how many vascular disorders the diabetic is predisposed to. So these high blood glucose levels result in higher risk for chronic, microvascular, macrovascular, and neurological disorders. And that's where the real issue with diabetes comes, in all of the short and long-term complications of the hyperglycemia. So sort of make my point with regard to how likely you are to encounter diabetes in your practice. Just like to go over some of these statistics. And so in this first one, with regard to prevalence, I'm comparing just in the last 5 years. In 2015, there were 30.3 million Americans who were diagnosed with diabetes, or 9.4% of the population. Now, this past year in 2020, that's gone up to 34.2 million, or 10.5% of the US population. So 1 in 10 people in the US have diabetes. Approximately 1.25 million American children and adults have type 1 diabetes. But type 1 diabetes is really just the tip of the iceberg. The majority of diabetics are type 2. Again, I'll be talking more about this in coming slides as I go along in this lecture. A lot of diabetics have been diagnosed, but in fact, the majority of that 34.2 million people have been diagnosed with diabetes. That is, they meet the diagnostic criterion. But there is another group of diabetics that are undiagnosed. 7.3 million of these active diabetics right now do not know they're diabetic. And in seniors, the percentage of Americans age 65 and older is at 25.2%. So 1 in 5 seniors has diabetes, because age is in fact a risk factor for developing diabetes. About 1.5 million new cases a year. Deaths. Diabetes remains the 7th leading cause of death in the US in 2015. And these deaths may be directly related to their diabetes, but more often it's related to their long-term complications that they've developed secondary to their diabetes. So here's just a slide to sort of give you a visual of that. Again, 1 out of 10 Americans have diabetes. And with relation to that, and with relation to pre-diabetics, as well, there is a huge cost to our society and to our healthcare system with regard to diabetics. About $245 billion in medical costs and lost work and wages. The medical costs for a diabetic is twice that of a non-diabetic. So it really impacts our healthcare system with regard to how much money we have to spend to care for diabetics, and also to our society, where we lose diabetics with in the workforce. So when I talked about long-term complications, this slide takes a look at how significantly diabetes affects these various long-term complications. So a person with diabetes compared to a non-diabetic is 2 to 4 times more likely to have heart disease. They're 2 to 4 times more likely to have a stroke. Diabetes is the leading cause of new cases of blindness. It's the leading cause of end-stage renal disease. It causes neurological damage, and as many as 70% of diabetics are going to have mild to severe nerve damage. About 3/4 of diabetics will develop high blood pressure as a result of their diabetes. And 60% of non-traumatic lower limb amputations are done on diabetic patients. So again, diabetes and the resultant and the high blood glucose that they develop is going to result in vascular damage from head to toe. Additionally, because diabetes is not just a disorder affecting blood glucose, metabolically, diabetics are also going to have elevated blood lipids or blood fats, and the combination of high blood pressure and high blood lipids is what contributes overall to these vascular damage that's done over time. So earlier when I talked about how many people are diagnosed with diabetes, there are very concrete diagnostic criterion that are used to determine whether or not a person has diabetes. So there are 4 possible ways to diagnose diabetes. The first is if the patient presents with symptoms of hyperglycemia or symptoms of chronic hyperglycemia, which again, I will talk about in a later slide what those symptoms are. But if a person presents with symptoms and what's called a casual plasma glucose level of greater than 200 milligrams per deciliter. The word casual in this diagnostic criterion refers to the fact that it is unrelated to when the person last ate. In other words, this is not a fasting plasma glucose level. It is a casual plasma glucose, unrelated to whether or not they ate. So if I were to present to my health practitioner and talked about some symptoms like excessive thirst, excessive urination, whatever symptoms I may bring up, those symptoms, in addition to the plasma glucose level of greater than or equal to 200, that meets the criterion for a diagnosed diabetes. The second possible way of diagnosing is if the patient has a fasting plasma glucose that is greater than or equal to 126 milligrams per deciliter. So greater than or equal to 126. Now, less than 110 is normal for fasting. There is another category that's greater than 110, which is normal, but less than 126, which is diabetic, which is called impaired fasting glucose. IFG, impaired fasting glucose. And I'm going to get back to that impaired fasting glucose in just a moment, but we'll progress through these other criterion first. The third way of diagnosing is if the person has a 2-hour postprandial glucose. Postprandial, that term means after ingesting a glucose load or after eating, essentially, is what it means. So if the physician or nurse practitioner or physician's assistant were to order a 2-hour postprandial glucose, the person would drink a 75-gram glucose load and have what's referred to as an oral glucose tolerance test. How many women out there today in this group have had pregnancies and had an oral glucose tolerance test as part of your prenatal care? Anybody? I bet you, I would.
Yeah,
I have.
yeah, I have.
Yeah, it's commonly done during pregnancy. And it's a different test than the fasting plasma glucose in that it's looking at how well your body is dealing with a glucose load. What happens to your blood sugar when you eat? It's great to know what happens to your blood sugar fasting, but more importantly, or equally as important, what happens when you eat? Or in this case, for the purposes of the test, you drink this sweet syrup that is 75 grams of glucose. The results from that, again, normally blood sugar is going to elevate, but how much it elevates is what's important here. With the 2-hour postprandial glucose, if it is less than 140, that's normal. All of us are going to have a little bump in blood sugar when we drink or eat, in this case, a glucose load. But if that blood glucose level is greater than or equal to 140, or I'm going to go back here, if it's greater than 200, you are diabetic. But there's this middle category again, just like with the fasting plasma. If it's greater than or equal to 140, but less than that 200, which is diagnostic for diabetes, you have then what's called impaired glucose tolerance.
Could I ask a question, please?
Yeah.
For those impaired categories, would
Yeah.
those people be considered pre-diabetic? Is that like a diet, like would they?
You named it exactly. So impaired fasting glucose plus or as well as impaired glucose tolerance are the two groups that are considered pre-diabetic. They are the diagnostic criterion for pre-diabetic.
And pre-diabetic is like its own diagnosis in its own right.
It is its own diagnosis, and it needs to be managed as a diagnosis, because without management, the likelihood is that it will, with age and with other factors, like if there's continued weight gain, and with that weight gain and age, there's decreased physical activity, though that pre-diabetes will develop into diabetes. So yes, it is considered a diagnosis of its own, and it has to be managed. It can be managed so as to really reduce the risk of progression to true diabetes. And then the last diagnostic criterion for diabetes is what's called a hemoglobin A1C, which is greater than 6.5%. And I will, in another slide coming up, I'll talk more about the A1C, because that is another important diagnostic tests for, not only for diagnosis of diabetes, but very important as well for management of diabetes, to help diabetics monitor how well they are doing and help physicians monitor so that adjustments in medications and diet can have information to work on. So I've talked about the fact that there are different sort of causes of diabetes. Either the person's not making enough insulin, or they're not using their insulin adequately. And that leads us to the classification of diabetes. There are really only 3 classifications that you need to be concerned about at this point in time. There are actually, as the bottom of this slide shows, there are other specific types of diabetes that they're actually numerous. There are genetic defects in insulin action. There are drug or chemical induced diabetes. But for our purposes, think about these top 3 as being the ones that you really need to know about. The first is type 1 diabetes. And type 1 diabetes results when beta cells in the pancreas are destroyed. And they are destroyed by an autoimmune destruction. The person's own immune system attacks beta cells and destroys them. And with the destruction of those beta cells, it leads to an absolute insulin deficiency. Absolute being no insulin is being produced naturally by the pancreas. But this is a small percentage of diabetics. Only about 5% are type 1 diabetics. Type 2 diabetics, which make up that additional 95%, either have a decreased production or an improper utilization of the insulin that they are capable of producing. And then lastly, gestational diabetes, or GDM, complicates about 7% of all pregnancies in the United States. I'm not directly going to address gestational diabetes. I'll refer to it here and there, but Professor Casey Lane will address it in one of her lectures on pregnancy and and the infant of the diabetic mother. But what you need to know is that the reason we have a concern about gestational diabetes is because for two reasons, really. One, that excessively high blood glucose that the mother has is going to negatively impact the fetus. And so the infant of the diabetic mother is going to have a set of health problems that are going to need to be managed, but they also can be prevented through good diabetic management of the woman during her pregnancy. So that's really important. But secondly, what's important is that developing diabetes during pregnancy is kind of like a stress test for heart disease. You know, if you get on that treadmill, you get chest pain, that tells us something about what's going on with your coronary arteries. Well, in this case, developing diabetes during pregnancy tells us something about how well your pancreas is managing the increased demands for producing insulin that pregnancy results in. So what you need to know is that pregnancy requires that the woman's pancreas is able to produce more insulin to meet the metabolic demands of the pregnancy. And secondly, understand that if that gestational diabetes is not well managed during pregnancy, that there are negative outcomes that can occur to the pregnancy and to the infant of the diabetic mother. All right, so a little more on type 1 diabetes. We know that the beta cells are destroyed. It's by an autoimmune process. It's not entirely clear why this autoimmune disorder develops. It's felt that there is probably both genetic predisposition as well as perhaps environmental triggers. But one way or the other, the autoimmune process goes awry and beta cells are destroyed. So as a result, insulin is no longer produced. Now, type 1 diabetes historically was referred to as juvenile onset diabetes because the majority of it did in fact occur in young people. So the onset is acute and it usually occurs before age 30. Not always, but usually. Again, this 5 to 10%, I really want you to think about 5%, because what's happened over the last decade or so is that the numbers of people with diabetes have climbed, but the number of people with type 1 diabetes has not climbed as rapidly. So type 1 diabetes is no less likely, it's just a smaller percentage of the full number of diabetics. That makes sense? Hopefully. So previously we called this juvenile onset. We don't call it juvenile onset anymore. And the reason for that is that young people can develop type 2 diabetes as well. So it's a bit confusing to call this one juvenile onset when type 2 can occur during childhood as well. The other incorrect name for type 1 diabetes, and I mention these names because I still hear them in clinical practice and I still sometimes read them in patients' charts, even though it's been, I think it's been 12 years since these new terms have been instituted and are the accepted terminology. The other term that you might hear for type 1 diabetes is insulin-dependent diabetes mellitus, or IDDM. The reason that's a misnomer or confusing at best is that many type 2 diabetics also require insulin for their management. So for your purposes, it's type 1 or type 2 or gestational, period. Those other terms are misleading, confusing, and basically incorrect, even though you still see them. You know, sometimes it takes, it's difficult for old dogs to learn new tricks with respect to changing terminology and such. So type 2 diabetes, let's sort of differentiate these. Heredity also plays a major role, but so do lifestyle factors. And lifestyle factors do not play a role in the development of type 1. Again, this was previously referred to as non-insulin dependent diabetes mellitus. But again, a misnomer, because a reasonable percentage of type 2 diabetics require insulin. So that's just wrong. Also has been called adult onset or maturity onset diabetes, but that's incorrect because we're seeing diabetes at higher rates. It was almost unheard of in very young people, but it is now seen in young people. And when we see it in very young people, it's usually a combination of genetic predisposition. There are certain ethnic groups that have higher rates based on genetics. But the other part of diabetes, type 2 diabetes occurring in young people, usually there is obesity involved as well. It almost always is a combination of those two things. And type 2 diabetes is going to be a combination of insulin resistance and inadequate amounts of circulating insulin. Type 2 diabetes actually has a much more complex pathophysiology than type 1 diabetes. Type 1 diabetes is easy. The beta cells don't produce insulin, period. Type 2, it's a lot more complex, and we'll talk a little bit about that for sure. So this slide helps, I hope, to explain a little bit about the natural progression of how type 2 diabetes develops. So the first thing that happens in a patient who's developing type 2 diabetes is that there is insulin resistance. That insulin resistance results in the beta cells producing more insulin. So the beta cells compensate by developing hyperinsulinemia. The beta cells are still healthy, they can produce insulin. And as blood glucose starts to climb, the beta cells respond by producing more insulin. So this term, high insulin being produced in the blood, hyperinsulinemia. So this can actually be tested for and identified in patients. So here we have the insulin resistance. The pancreas responds by producing more insulin to keep blood glucose normal. So when this person has a blood glucose level tested, they're going to look normal. They're going to look fine. The blood sugars are fine. Over time, this demand that's placed on the beta cells results in beta cell exhaustion. We overtax, or the beta cells are overtaxed and they poop out. And that's the secondary defect is that now the beta cells have been essentially damaged by too much being asked of them. And at this point in time, we start seeing some actual symptoms of either prediabetes or we can see the liver trying to compensate. And the liver compensates by increasing hepatic glucose production. And that's because there isn't enough insulin at this point. And that in combination is going to lead to the impaired glucose tolerance and the impaired fasting glucose, the prediabetes. Without anything to interrupt that process, as the person ages, and as I said, oftentimes with age, we see decreased physical activity, and we might see, with age, we might see increased weight gain as well. And then the person develops type 2 diabetes because now they have relative insulin deficiency. Relative being, yes, they produce insulin, but not enough to meet demands that are present, and also to overcome the resistance to what insulin's there.
Professor, I just have a quick question.
Yeah.
Where you were saying when you're pre-diabetic, were you saying that it's at the square that says IGT and IFG? That's where you would be considered. Okay.
That's right. Yep.
Thank you.
I have a
Absolutely.
question too.
What's that?
Can I ask a question too?
Yes, go ahead, Libby.
Is there a place along here where it's not reversible anymore? Is there a place where?
Well, it's kind of interesting. Depending upon the level of management that the patient is capable of. There are type 2 diabetics that meet all of the criterion for diabetes. They are diagnosed diabetics, but with a real turnaround, and by that I mean a change in diet, a decrease in weight, and an increase in physical activity. And these usually have to be fairly substantial to turn things around. But yes, they can be, a type 2 diabetic can essentially achieve a non-diabetic status basically through lifestyle changes. That is a pretty big ask for most people. Hey, you got to take off 60 pounds. You've got to go from being a couch potato to getting regular daily exercise. And oh, by the way, you're eating all the wrong foods. Now,
Alcohol too, right, Professor? Alcohol has a lot to do with it. If you drink a lot.
Alcohol can factor in. Yes, it can. But I think all of you out there know, well, most of you know, some of you have been thin since day one and it's never occurred to you, but most of us recognize that losing 5 pounds is hard. Losing 10 pounds is hard and keeping it off. Changing your diet from a diet that's all wrong to a diet that is appropriate for to change your metabolism is a really, really difficult thing to do. And all of those things are particularly difficult to do in a culture where we have eliminated so much normal exercise that if you don't go to the gym or exercise independently, you're not getting enough exercise to have any impact. Our culture has done that. We drive, we don't walk. We everything we do, not everything, but so much of what we do, the exercise has been taken out of it. And exercise is absolutely critical for normal, healthy metabolism. So additionally, our culture pretty much ascribes to a diet that stinks. And to tell people who live within a society where it's, it's difficult to get enough exercise, it's difficult and requires education and self-motivation and basically being able to do it. It's really hard. I want to impress upon people that people don't sort of gain weight and become type 2 diabetics out of being lazy, and it's just not that simple. We have not created a culture where healthy eating and healthy exercise and food availability and all of that is conducive to healthy metabolism, healthy weight, and preventing type 2 diabetes. We don't. So judgment needs to be taken out of the picture. Absolutely taken out of the picture. You might say, well, I do that. Well, that's wonderful. And perhaps you have had more opportunities to do that. But there are plenty of people who have not, or who haven't learned how, you learn what the culture tells you. And if the culture tells you that all those good foods are in the middle aisles of the grocery store where everything is processed and oh, by the way, by the time you get to the produce aisle, you've kind of loaded up your basket and your budget's blown. And oh, by the way, those vegetables and fruits are very expensive anyway. So let's forget about them, right? But anyway, I digress. We're gonna move on here. So just so you know, this little piece of the pie, the hepatic glucose production, that happens because of decreased insulin production. Because glucose production from the liver is related to insulin being available.
You say it happens because of decreased insulin production?
Say that it's related to decreased insulin production, yes. So that's why that occurs after the beta cell exhaustion. Now we have a decreased insulin production, and that stimulates, unfortunately, that tells the liver to increase glucose production. So that, as well as the insulin not being available, now that leads to your prediabetes and progressing on. And then, of course, this can and does progress to insulin requiring type 2 diabetes, which is why we don't call type 2 diabetes non-insulin dependent. And I have one other slide here to show you that basically talks exactly about what I just said. So insulin, it all starts with insulin resistance. And that increased hepatic glucose production factors into the hyperglycemia. But additionally, the beta cells become exhausted. They reduce their insulin secretion, and that also leads to the hyperglycemia. So now what started up here affected different systems and results in the hyperglycemia. All right, I had talked before when I was talking about diagnosing diabetes. I talked about if the person presents with symptoms and a glucose elevated greater than 200. Well, these warning signs of diabetes are really what I was talking about. And type 1 diabetes, which again occurs acutely, the symptoms that we're going to see in these people include frequent urination. They are producing more urine. Why are they producing more urine? Anybody have a guess?
The body is trying to get rid of all that extra glucose.
Exactly. And if the kidneys say, blood goes to the kidneys and the kidneys say, hey, we have way too much glucose in this blood. We've got to get rid of some of it. So it pulls glucose out of the blood, the kidneys do. But what comes with the glucose? Water.
Water.
Okay, glucose that is pulled out of the blood by the kidneys draws water with it. So urine volume increases by quite a lot. It very noticeably. Like all of a sudden the person's like, I am just urinating all the time. So as a result of that, they become dehydrated. They become thirsty because they're dehydrated. So now they're in this little cycle of, I drink because I'm thirsty, but the kidneys don't care that you're thirsty. They're going to keep pulling out glucose. And as they pull out glucose, water is pulled out as well. People with type 1 diabetes also become hungry. And the reason for that is because they're not able to use their circulating glucose. And so cells perceive themselves to be starving. Well, they are, because they can't use the glucose that is available. Extreme fatigue, for the same reason. The cells are not getting the fuel that they require. And irritability. And the irritability is related to the fact that the central nervous system, the brain, uses glucose exclusively for fuel. And without that glucose, there are some signs of irritability occur as a result. It's a neurological finding. So these symptoms on the left are signs of hyperglycemia. When they come on acutely, as in the type 1 diabetic, they know something's wrong, and they will seek medical attention. And if they don't seek medical attention, they eventually have to, because they will develop, they will become sick enough that they will have to have medical attention.
I have a question.
Yeah.
So you said extreme fatigue is because the cells are not getting what?
Glucose.
Okay.
So over here on the right, we have symptoms of type 2 diabetes, or more. You can consider them warning signs, but they're really symptoms of sorts. So first of all, type 2 diabetic can develop any of these symptoms, but they develop them so slowly that they don't recognize it, because that cycle that I showed you of development of type 2 diabetes occurs over years. So the person doesn't recognize, they don't think, oh, I'm urinating more. I have to get up in the night to urinate. They think, oh, I'm getting old. I have to get up in the night to urinate. They don't see it. It happens very slowly, very gradually. And they just don't make the connection. So any of these symptoms can occur, but they occur over a long period of time. But what ends up happening is that type 2 diabetics often will develop frequent infections. Wound infections are probably the most, I would say would be the most common, but additionally, urinary tract infections are very common. All sorts of infections, really, but those are the two that are most prevalent. And these, well, never mind. I'll talk about that in a minute. Blurred vision can be another symptom that develops with chronic hyperglycemia. Cuts and bruises that are slow to heal. Neurological damage, which results in tingling or numbness in the hands and feet, what is sometimes referred to as diabetic neuropathy. Recurring gum, skin, or bladder infections. So they get frequent infections but they're treated and they come back, and they're treated and they come back. This last category here that's, I think, perhaps most important is that a lot of these people don't have any symptoms at all. But frequently, it is one of these symptoms that results in them seeking medical attention that then gets them diagnosed with their type 2 diabetes. The problem with that is that these symptoms tell us that damage has already been done. There are some estimations that type 2 diabetics typically have type 2 diabetes for 5 years or more before seeking medical treatment for one of these other problems. And so damage has already been done. And in fact, we see type 2 diabetics who come in, there's every reason to believe that they've had type 2 diabetes for as long as 10 years. And in that period of time, vascular damage is being done, neurological damage is being done, and eventually that has them seek out medical attention. So that's why type 2 diabetes, in a way, is almost more serious than type 1 diabetes. Type 1 diabetics have to manage their diabetes. Type 2 diabetics either don't know they're diabetic, many of them, or by the time they find out they're diabetic, a good bit of damage has already been done. So people tend to think of type 1 diabetes as like the real serious diabetes, but in terms of overall damage, type 2 probably is the more serious. Just doesn't get credit for it. Let's see, anything else? All right, so when hyperglycemia is present, and when it's present over time, the person is going to develop either microvascular complications or macrovascular complications. And as a result, with microvascular, again, as its name implies, small vessel disease includes retinopathy, which is damage to the blood vessels of the retina, which is the leading cause of blindness in adults. Nephropathy, which is kidney disease, occurs in a fairly high, about at least, probably as much as a quarter of all diabetics develop some degree of neuropathy, nephropathy, kidney disease, and resultant decrease in renal function.
Can I ask a question?
Yes,
So the buildup in the glucose in the veins, so is it the increased viscosity that just causes all of this? What?
it's not.
Okay.
It's not the increased viscosity, but glucose it's not the glucose in the blood that causes the damage to the vessels.
Mm-hmm.
It is the metabolic cascade of events that hyperglycemia causes. For example, diabetics' blood lipid profiles are usually way out of whack. Their triglycerides are very high. Their cholesterol is very high. Their LDLs are way out of whack compared to their HDLs, which are consider HDLs to be the healthy blood lipids, and the LDLs, the lethal blood lipids. That is one of the biggest problems. Additionally, a high percentage, at least 3/4 of diabetics develop hypertension. Hypertension is also going to damage blood vessels. There are other metabolic changes that occur, all of which can compromise blood vessels. So it's the glucose itself doesn't damage the blood vessel. It's
Okay.
it's the impact on metabolism and other metabolic factors.
Great. Thank you.
So neuropathy. Neuropathy is damage to the neurological system, and that results in peripheral nerve disease in a majority of diabetics, that can range from the very minor sort of just pins and needles in the feet to very, very, very severe, where there is absolutely no sensitivity at all to in the extremities. And more on that later, but that can be a big problem. But in addition to peripheral nerve disease, autonomic nerves can also be damaged. So nerves that impact the functioning of the cardiovascular system, the heart, for example, nerves that govern digestion and the GI tract. So nerves all over the body can be damaged by the chronic hyperglycemia. It's estimated that with large vessel disease, the macrovascular, about 75% of diabetics die from some form of macrovascular disease. They include coronary artery disease, so they die from heart attacks, peripheral vascular disease, where their blood vessels to the periphery are damaged, and amputations and non-healing wounds result, and cerebrovascular disease, or blood vessels to the brain, resulting in strokes. So small vessel disease, microvascular, the eyes, the kidneys, and the nerves, and macrovascular, large vessel disease, coronary arteries, peripheral vascular arteries, and cerebrovascular arteries. Hang on one second, I didn't realize my phone was on. Sorry about that.
Can I ask
Um,
a question?
Yes, please do.
Are are neuropathy and peripheral vascular disease the same or connected? Does one lead to the other?
Neuropathy is damage to nervous system or
Oh,
nerve damage. And that includes both peripheral nerves as well as autonomic nerves. Okay. All right. What time do we have? Okay, it's 11:30. So we're going to we'll take a 10-minute break, and I'll come back and lecture for another 50 minutes. I guess I've actually lectured for an hour, but we'll be done on time. But take a little break, go to the bathroom, get a glass of water. I personally am going to make a cup of coffee, but you
Can
do
I
what
ask
you
one
have to
question?
do. Yes, please do.
So if you have neuropathy in the autonomic nerves, could that be one of the causes of high blood pressure? Because you're
Yes,
damaging.
that definitely can factor in, but yes, it can. And autonomically, we find that patients have heart rates that are abnormal. For example, their hearts don't know to react appropriately to
Like this
standing.
movement. Yeah. Okay.
So postural hypotension can result.
Yes.
And really, these autonomic nerves damage. I will be talking more about them. Yeah, they can wreak havoc for sure.
Okay, just wondering what that meant.
Okay. All right. We'll take a 10-minute break. We'll be back at 11. We'll say 11:40. Okay. I guess that's a little shy, but all right. Till then.
Jenna, you have me dying laughing right now because I'm just looking at your face expression.
Okay, my video was off.
Because your camera's on, so the whole time you're like looking at the screen, whatever you're looking at is you must be putting full thought into it because your facial expression is hilarious. I've been sitting here just dying like for 5 minutes straight. You sat in the same position.
I don't know why. Like, you can see me right now. My video says
Yeah,
that
I can see you.
off. That's so weird. Well, great. Now I know that even when it says that my video is off, you guys can still see me.
Oh my God, I wonder if you've been knew that because it happens all the time. Every class, we'll go on break and your camera be on. You'll be staring dead into the camera.
Oh my
And
God.
I'll just be looking at your facial expressions. And today just made me laugh because you sat in the same position for like 3 minutes, just in full
I've been
thought.
trying to get things done for like the whatever that thing is, the case study for tomorrow. That's what I'm doing right now, and I'm like reading all the lab values and stuff, and they're like,
oh, that's what I'm doing. I'm actually watching those videos that Cassie Lane put under them. So I just been analyzing the video, but it's so funny. You should. I wish I could screenshot.
Yeah, I don't know what to do about it. Since I turned my video off. Let me see. Can you see me now?
I can see you still.
I just turned it off. I don't know.
You can't see yourself though, Jenna?
I can't see myself at all.
On the top of the
wow.
screen, actually not the top of your screen. If you go into the Moodle, the Zoom regular app, sorry, this is sounding really dumb. The Zoom home app and click on your settings, you can test your camera out and see which one you're using or if it's allowed access.
Okay,
I think the camera works too well.
Seriously, because I had no idea, and I wonder how many times that has happened where I did not.
Class, I'm dead serious.
The best part's going to be when this entire thing is recorded and put on YouTube.
Awesome, and I'm going to be like, hello. Super close.
I think ever since last semester, you never go on hold. Your camera's always on.
That's awful. Thank you for telling me.
You're welcome.
Hello, folks. I'm back.
Hello.
All right, everybody take care of their immediate needs in the last 8 minutes, hopefully. All right, we'll continue. And if I get to 12:30 and I'm still talking, somebody can remind me that it's time to end class and I'll wrap things up, all right? All right, so let me share this screen again. Okay. And just 1 second. Okay, so there were the complications of chronic hyperglycemia or the long-term complications that develop with diabetes. All right. Complications of diabetes may develop in anyone with type 1 or type 2 diabetes. And I want you to emphasize to patients that even if they are not required to take insulin, that he or she does have diabetes and must control the disease to prevent further health problems and complications. There is somewhat of a misconception among patients that if I don't need insulin, so my diabetes can't be too serious, but that's incorrect. Without good control of their blood glucose levels, be it with diet, medication, or change in lifestyle, they will develop long-term complications. So it's important that type 2 diabetics recognize that. That also makes it very important for type 2 diabetics to be diagnosed because they can't make changes in lifestyle without that knowledge that they have developed type 2 diabetes. So that leads to, how do we find them? What are our means of finding these diabetic people out there? So with regard to screening, all individuals over the age of 40 should be tested. And if their fasting plasma glucose is normal, they should be retested at 3-year intervals. Testing should begin earlier than that and be more closely monitored in individuals who are obese, because obesity, particularly obesity with in terms of central obesity, where the person holds weight in their abdominal region, that type of body fat is the type of body fat that interferes with insulin usage. It creates insulin resistance. So obesity, people who are obese need to be tested earlier and more regularly, and perhaps with more than just a fasting plasma glucose. If you have a first-degree relative with diabetes, if your mother is diabetic, for example, or your brother, again, earlier, more closely. If you are a member of a high-risk ethnic population, so some of the ethnic populations that have higher rates of diabetes include the Native American populations, have perhaps they do have the highest genetic predisposition. Hispanics have a higher rate. The African American population in the U.S. is higher. Asian population is higher, particularly the Pacific Islanders. So whereas the non-Hispanic white population is about 8%, Native American population is close to 16. The Hispanic population is close to 13, as is the African American population, and Asians being at about 9. So different groups have higher predispositions to type 2 diabetes. If you've had gestational diabetes in the past, or you've had a baby weighing greater than 9 pounds, that puts you in a higher risk group. Certainly, if you've had gestational diabetes previously, you are automatically in a higher group. If you've had big babies, now 9 pounds might not sound too big to you, and certainly there are couples who normally produce large babies because they are large people. And we're not really talking about them, but just overall, if you've had large babies in the past, and particularly if you've had, maybe your first baby was 9 pounds, and then your second baby was 9 pounds, 8 ounces, and then your third baby was 10 pounds. Hopefully somebody will have identified that that's a real red flag. Because it's kind of interesting. Although insulin does not cross the placenta, what happens is that the fetus during pregnancy produces more insulin to counteract the high blood glucose that it is being affected by. So the maternal blood crosses the placenta, brings with it that high blood glucose. And the fetus, in response, produces more insulin. But the fetus produces what is known as fetal insulin. And fetal insulin is a growth hormone. So it's not just that the fetus is exposed to high blood glucose and has more fuel for growth, but additionally, it is creating more of a hormone that results in fetal growth. So these babies can get very large.
Professor, can I ask you a question?
Yes, yeah.
Sorry to interrupt you.
No
Can
problem.
gestational diabetes cause low birth weight in a baby?
Gestational diabetes, okay. If the woman with gestational diabetes is actually a type 2 diabetic who is non-diagnosed, does that make sense? So some women with gestational diabetes develop it during pregnancy, but when they are non-pregnant, their blood glucoses are normal. Other women have their type 2 diabetes first identified during pregnancy because they're tested during pregnancy, okay? But what if that woman has been diabetic? We'll just throw out a number. She's been diabetic for 5 years and she has vascular disease. Her ability to perfuse enough blood to the developing fetus that that infant can be small for gestational age. Does that make sense?
Yeah, it does. Thank you.
Yep. Okay.
I also wanted to ask about the high-risk ethnic populations. Is it genetically predispositioned, or is it also the fact that these people, for example, Native Americans, were given really crappy food to eat, like in rations and stuff like that, that has also influenced that?
That's a really good question, and it is definitely there is genetic predisposition in these groups. And that is further complicated, perhaps, by cultural differences in eating and lifestyle. So, but there is a higher risk genetically also. It's been pretty well documented by looking, especially twin studies. These are absolute genetic predispositions. Okay.
Professor, if you don't mind.
I don't.
You said that the fetal growth hormone increases the fetus's growth rate during pregnancy.
Rate of growth, yeah.
Does that regulate after the baby's born, or will the baby consistently have an increased growth rate?
That does once. I won't get into the whole thing about what their risks are as neonates, but it does eventually, because the high blood glucose that they've been exposed to when you take that out, their production of insulin then is decreased. Additionally, there's a transition period between the production of fetal insulin and normal insulin. So it does self-regulate, but these babies often have, in addition to being large, they have some problems as a result, because they have enlarged organs as well. So it's not just fat deposits on these babies, it's excessive growth. And oftentimes their excessive growth causes them some long-term problems. So we're seeing less of that with better screening of pregnant women, fortunately, but it certainly still can happen.
So it can affect the baby's organs throughout their life. So like my mom had diabetes, and my sister, this is all like clicking now. My sister's had major problems with she's had like things removed and she's had her insides kind of rearranged, and she's always had these issues with her body. And I wonder if that's because my mom had gestational diabetes when she was pregnant with her, because she was large too. She was 10 pounds something.
So she definitely had what we refer to as macrosomia, and the other part of that macrosomia is called organomegaly, where the organ growth, because if it occurred, if growth rates of those organs occurred at a very high rate, yes, organ problems system-wide can develop. So it's
Oh,
possible.
interesting, yeah.
I'm not saying that's what happened with her, but I'm saying that's entirely possible.
Does this
All
have
right,
any
so
link- sorry, does this have any
also,
link to jaundice?
What's that?
Does it have any link to jaundice?
Yes, but that's more complicated than I can get into at the moment. Maybe Casey Lane will, though, when she talks about infant of the diabetic mother. So, because there is some relationship there. If a person is hypertensive, if that's all that they're diagnosed, they come into the doctor's office and then they say, "Oh, your blood pressure is high. You're, 40 years old and you have a blood pressure of 166/84. That's hypertension. Why do you have hypertension? Maybe the why is because you are diabetic as well. So any hypertensives should be screened for diabetes. If a person's blood lipids, their HDL, if it's less than 35, they should be tested, or if their triglycerides are greater than 250, they should be tested for diabetes, because diabetes metabolically wreaks havoc with the body's blood lipids. And if they have ever in the past been positive for impaired glucose tolerance or impaired fasting glucose, they should be tested much more regularly and closely than the average person. So if you're in a risk group, you need closer monitoring than otherwise. So it's important that we screen and identify patients who are developing diabetes or who have developed diabetes, because we've shown clearly, this one particularly large study called the Diabetes Control and Complications Trial, that study showed definitively that if we can lower, or if that person is capable of lowering their blood glucose concentrations, either through lifestyle or medication, if that can be accomplished, the development of the diabetic complications that are life-threatening, coronary artery disease, cerebrovascular disease, life-threatening disorders, those can be decreased significantly by management of diabetes. The good news is that sort of study and the results from that sort of study have been very helpful in increasing motivation to work towards tighter control for the diabetic, because that study and others have shown that it's well worth the future outcomes, and are worth it by lowering blood glucose levels. So as we look at this, the results from this particular study, in the intensive treatment group, where average blood glucose could be maintained at about 155 or approximately 7 of hemoglobin A1C, compared to the standard, whose blood glucose was elevated and shown definitively elevated by the A1C. In the intensive treatment group, retinal eye disease was decreased by 76%, neuropathies were decreased by 60%, and kidney disease by 56%. Additionally, the macrovascular diseases were also significantly reduced. So just a nice demonstration of how helping people manage their diabetes well is worth the work involved. So that brings us to diabetes management. Diabetes management is going to be multifaceted. It's going to be achieved through a combination of management therapies, including nutrition therapy and exercise, monitoring, blood glucose monitoring, and pharmacological therapy and education. So all of these are going to play a role in management of a patient's diabetes. So monitoring, the mainstay of monitoring for a diabetic is blood glucose testing. Blood glucose testing can be testing that is done in the lab, where the patient has bloods drawn in the lab, and the lab identifies the glucose levels, or it can be done with a glucose monitor. So the introduction of glucose monitoring and home glucose monitoring and continuous glucose monitoring has really played a huge role in a person being able to manage their diabetes, because knowing what your blood glucose level is allows you then to make decisions in terms of your diet and exercise, and helps your physician make decisions with respect to medications that are going to allow for control of those blood glucose levels. The other form of and I'm going to go back for a second. That blood glucose testing, however, really only gives us a snapshot in time. It tells us what their blood glucose is right then and there. Glycosylated hemoglobin is the hemoglobin A1C that I mentioned earlier. It's also referred to as a glycosylated hemoglobin level. This blood test, hemoglobin A1C, reflects the average blood sugar level for the 2 to 3 month period before taking the test. So this isn't just a snapshot in time, rather it gives us sort of a look at what has gone on previously. Wait a minute, hang on just one second. Actually, I already mentioned that with regard to blood glucose monitoring. So this is the slide I wanted you to see. So the glycosylated hemoglobin testing, or HbA1c, it's also commonly referred to, or the GHB, the glycosylated hemoglobin, tests the rate of formation that is directly proportional to the ambient glucose concentration. So what that means is that this blood test takes a look at a number of red blood cells and specifically looks at the hemoglobin to determine how glycosylated it is, meaning how many glucose molecules have attached to that hemoglobin. And the reason it's able to give us information about 2 to 3 months is because red blood cells' lifespan is approximately 120 days or approximately 3 months. The A1C is an average of glucose concentrations that has occurred over those previous 3 months. Because if you have red blood cells that are turning over, we'll say at approximately 3 months rate, a single blood sample is going to have some brand new red blood cells, some very old red blood cells, 3 months old approximately, and everything in between. And so if we look at how glycosylated the hemoglobin is in that sample, it gives us a number that's the average of all of those red blood cells. And so it tells us what's been going on previously, as well as opposed to the blood glucose monitoring that tells us what's going on immediately. Does that make sense? Yeah, good. Okay. So in the presence of hyperglycemia, the rate of glycosylation increases. And we look for a percentage that tells us about what's been going on. Now, in a non-diabetic, that number ranges generally between 3.5 to 6. In diabetics, we aim for them to have an A1C that is less than 7%. That's the American Diabetic Association's recommendation. And the American Association of Clinical Endocrinologists would like it to see it even a little bit lower at 6.5%. And one of the things I think that's important to know is that in the non-diabetic, there is a fairly significant range of normal. One of the things that more recent research has shown is that people at the low end of normal do indeed have lower incidence of a variety of diseases, including vascular diseases, but also cancers as well. Keeping blood glucose at the low end of normal is healthier for us, for everyone, not just diabetics. So as we talk about management of diabetes, a lot of the things that I'm going to mention are not just good for diabetics. They're good for all of us, every one of us, because the low end of normal is a healthier place to be with regard to A1C, the hemoglobin A1C. So the A1C we think of as telling us a little bit about fasting glucose and a little bit about postprandial glucose at the same time, because A1C is a reflection of what's going on continuously. So whereas fasting just tells us about what's going on then, and postprandial is just what happens in response to eating, A1C is actually telling us about all of it, what's gone on over time, because some diabetics have pretty good fasting blood glucose levels, not such great postprandial. And the A1C is going to tell us about that. So A1C is going to show our average glucose concentration. And here's the relationship of the A1C to blood glucose levels overall. A person with a 6% has an average plasma glucose of about 135. The higher we go on the A1C, the higher the average plasma glucose level is. So when we get it up, when we see patients with high HbA1cs, we know that their blood sugars have been quite poor. And of interest, with regard to A1C and normal folks, and that includes diabetics and non-diabetics, the more more regular exercise a person gets, and the less high glycemic foods a person consumes, the lower their A1C is going to be. So for each and every one of us, eating right, and I'll talk about right later on, and exercising regularly is going to improve our A1C to levels that are now known to be associated with decreasing morbidity and mortality statistics. So with regard to management, another circle on that management slide was medication. And certainly insulin therapy is one of the medications that is used to manage diabetes. And as well as oral agents, as well as another group of medications called incretin mimetics. And I'm going to go over all of these in more depth for sure. So insulin can be given by manual injection. It can also be given by a pump where insulin is an insulin pump is worn or potentially implanted. By pump, insulin output can very much approximate what a normal pancreas does. Insulin therapy can also be given by inhalation. We've had inhalation insulin available in the US in the past. It's not currently available, but there are some newer formations of inhaled insulin that are currently in the pipeline. Our oral agents work by different means. Some of them increase insulin secretion by the pancreas. Some of them decrease insulin-mediated glucose production, which is by the liver. Some of these medications delay glucose absorption, and some of them improve sensitivity to insulin. And some of them do a couple of these things, which is great. They work in more than one way. And these incretin mimetics are the more recent class of synthesized hormones that essentially mimic the hormones that are naturally produced in the gut. So we'll start with insulin. We think of insulin I think many people think of insulin very simply as, insulin allows the cells to utilize glucose. And that is true. But insulin is involved with both transport and metabolizing glucose for energy. It allows the cell to metabolize glucose for energy. Insulin also stimulates storage of glucose in the liver and muscle glycogen, in muscle as glycogen. Insulin signals the liver to stop the release of glucose. It also enhances storage of dietary fat in the adipose tissue. and it accelerates transport of amino acids into
I'm
cells.
sorry. What do you mean by enhances storage?
By that, I mean that insulin contributes, all right, if the cells are getting enough glucose, insulin is part of the process where the extra glucose is converted into dietary fat and stored.
So does it make that process just more efficient?
Yes. Yep.
Okay.
Exactly.
Thank you.
Yep. And it accelerates the transport of amino acids into cells. So it's not just dealing with glucose. It also inhibits the breakdown of stored glucose, protein, and fat. So insulin plays a much bigger role in in metabolism than first meets the eye. Plays a lot of roles. So insulin categories include rapid acting, short acting, intermediate acting, and very long acting. So these, as their name, I mean, their names are pretty clear cut. The rapid acting start acting quickly, but so their onset is rapid, but their peak and duration are going to be shorter. And as you go up this ladder, the very long acting is going to have a slow onset. These very long acting are considered peakless and is of long duration, as much as 24 hours. So let's take a look at the next little chart here. In fact, the next two charts. And these three are considered to be our rapid acting. They start working very quickly, and 10, 15 minutes is chart says 10 to 20. I'll go with that. Everybody's different as to how that insulin is absorbed from the subcutaneous tissues. And it is going to work for about an hour and a half to 2.5 hours, or it's going to peak at an hour and a half to 2.5 hours, excuse me. By peak, I mean that's when it is working at its most, it's lowering blood glucose at the most at that point in time. And then it has a duration of 4 to 5 hours. And then we have mixtures of insulins that are part short acting and part longer acting. And these mixtures, as you might be aware, insulin can be mixed in a syringe where we draw from 2 different vials, or we can get pre-mixed. And these two, the Humalog 7525 and the Novolog 7030, are what we call pre-mixes. And they have the advantage of starting early because they have some of the rapid acting insulin and then has some of the longer acting insulin, the intermediate acting. Regular insulin is what we consider to be short acting. Its onset of action is about 30 to 45 minutes. It peaks in 2 to 4 hours. And as you can see, it has a longer duration than the rapid acting. And let's see, that's the regular, the NPH. I don't know if you can see the bottom of this slide.
Professor, do we need to have a good handle on which one of these would be rapid, long, short?
Okay, I'll tell you, the rapids are right here. Lispro, Aspart, and Glulisine, or also known as Humalog, Novolog, and Apidra. Apidra we don't use in this. This is more of a Canadian insulin. We use primarily in the US Humalog and Novolog are what you're going to see. And the regular insulin is certainly still used, but it is not as rapid acting. It's considered to be short acting. And then NPH is the intermediate.
Can I ask a question too?
Yeah.
Is it called regular insulin because it's more like natural insulin in our bodies?
I don't know who named it, but no, I don't know why they named it regular, quite frankly. It was one of the regular and NPH were the first two insulins in development. And
yeah,
but our bodies only naturally make one insulin.
That's true. Our bodies only make one type of insulin. Exactly. These other insulins have components that slow the breakdown of that insulin into working insulin.
Hi, my pharmacology instructor.
Yeah.
She just basically, it has to do with like how early they were developed. So the regular is like first generation.
That's
like what you
exactly.
said.
But why they
Yeah.
specifically named it regular, I really
Now
have
they've
no
got
idea.
these more advanced mixes and they might be like second, third generation.
That is exactly true. But again, why they named it regular, I don't know. But I do know that it's considered to be short acting because compared to NPH and compared to our long acting, which this slide is cutting off the bottom, but let me go to the next slide so I can show this to you. What I want you to be aware is that these two slides are essentially telling you the same information, but it might be slightly different because I want you to be aware that different charts have slightly different information, but on a test question, I will never nitpick between charts, or the previous chart was from your book. Okay. This is a pretty standard chart. I want you to just be aware of what's rapid, what's short. This NPH is our intermediate, and then we've got our long-acting glargine, also known as Lantus, and there are a couple of other long-actings as well. There is what's called Levemir. But
just doesn't want to do it.
If you know glargine and Lantus, you'll be in good shape in terms of insulins that are most typically used in this area and what you need to know in terms of testing. So glargine and Lantus and Levemir are long acting, and as you can see with respect to administration time in relation to meals, there's no relationship. We don't worry about meals because this insulin works for 24 hours. So many people getting Lantus and Levemir get one dose a day, but endocrinologists have determined that if you split that dose of Lantus, we'll say, for example, into 2 half doses at 12 hours apart, they actually get a smoother, more well-regulated blood glucose levels for that 24 hours. So you can definitely see this given daily, but you can see it given twice daily, even though it's 24 hours duration. Okay, because they got a half a dose at each of those time frames. So rapid acting, again, is going to be, we do think in terms of meal planning with our rapid acting, because we don't want to give a rapid acting dose and have it start to bring blood sugar down unless the person has either recently eaten or is going to eat within the next 15 minutes. Okay. So these really are related, we need to know about meal planning here. Short acting, same thing. Our intermediate, we want to make sure that if I'm giving intermediate, we want where its onset is at approximately an hour to an hour and a half, we want to make sure that the patient is going to be eating in that next hour to an hour and a half. Because as the insulin takes effect, we need to make sure that there is blood glucose. We know it's going to lower blood glucose, so we need the person to be eating so that blood glucose doesn't drop too low. Does that make sense to everyone? Okay, so if you're giving morning Lispro to your patient in the hospital, you want to make sure that their tray is going to be there soon. Okay.
And you might have already covered this or it's coming, but rule of thumb on how they would decide on rapid versus short versus intermediate, is that coming up?
Yeah. Rule of thumb with regard here, I'll get to it. I will talk about that.
Sorry.
No, that's okay. So we have many patients in the hospital who are on what they call a sliding scale. Okay, we take their blood glucose level, and then the sliding scale gives us an order for how many units of the rapid acting blood insulin we're to administer to that patient. So these sliding scales are used very, very commonly in the hospital setting for sure. In fact, the sliding scale typically is going to be blood glucose levels checked 4 times a day, before each meal and at the hour of sleep. Another point to remember regarding insulin is that you only use an insulin syringe for insulin administration. Insulin syringes are not measured in volume, they are measured in units. As it turns out, insulin is going to have 100 units per milliliter. And all insulin used for injection is going to be what's called this U100, which is that 100 units per milliliter. So use an insulin syringe for administering insulin, and do not use an insulin syringe for anything else. They're not considered interchangeable syringes. So typically, with regard to insulin ordering and who gets what with regard to types of insulin, very commonly what you're going to see, it depends on the degree of how tightly the physician or nurse practitioner wants to manage blood glucose levels, because we can't necessarily, at least with insulin injections, we have to be careful that we're not going to give insulin that is going to result in hypoglycemia, low blood glucose levels. So we can administer insulin that will get them improve their blood glucose levels dramatically, but we don't want to drop those levels too low. So what very commonly we see will be a rapid acting with an intermediate acting or with a long term. So you might see a patient who gets their Lantus, which is long acting, but they might get 2 or 3 doses of their rapid acting based on their blood glucose levels. But patients at home aren't necessarily, they're not going to necessarily be testing their blood glucose as frequently as we do in the acute care setting. So for those patients, they may only get their long-term insulin and maybe check their blood glucose once or twice a day, depending. There's a lot of variation for that with regard to how tightly controlled and how motivated they are to be testing their blood glucose level. And then we have another whole category of patients who use insulin pumps, and I'll talk about that shortly. Did I answer your question about how insulin's ordered? Yes, no? Yes? Okay.
Thank you.
Yeah, you're welcome. And if I didn't, I can come back to that. We've seen this slide, we've gone over that. Again, just to be very clear though, if you're administering insulin based on a sliding scale, it is going to be a rapid acting, or at the very least, a short acting insulin. You wouldn't administer an intermediate or long based on the sliding scale. So insulin regimes are going to vary. They're going to vary from 1 to 4 injections per day. Peakless varieties are being used more frequently. They're a simpler regime for patients to follow at home. So a combination of short-acting insulin and longer-acting insulin might be a type of regime. And the 2 general approaches are conventional, which are these, or intensive, where the patient is testing their blood glucose frequently and administering short or rapid insulins more frequently. Intensive, we also use the term intensive insulin therapy for patients using insulin pumps. If you are mixing insulin, and as I said, we have both premixes and we can manually mix insulins. Regular NPH can be mixed and pre-filled. So we do mix these 2 together commonly, and we can pre-fill syringes for in home care situations. For example, the visiting nurse might go in once a week and pre-fill insulin for her patients who aren't capable of doing that on their own. NPH and Humalog can be mixed, but has to be given within 15 minutes. And the last point of our day today is that Lantus cannot be mixed with other insulins, and pre-filling is not recommended.
I had a question because when we mix it, is it clear before cloudy?
Thank you. Yes, it is. It's clear before cloudy. That's the rule for mixing. And the reason for that is the clear, which is our short or rapid acting insulin. We don't want it contaminated by our longer acting insulins. Whereas the longer acting insulins don't suffer the same way by a slight contamination because they're basically made up of a combination of insulin. So clear before cloudy, because we want that rapid acting insulin to absolutely remain active, rapid or short administration. Okay, so those are your guides for mixing. I think you've reminded me. I think I'll put a statement about clear versus cloudy in that slide at some point. That'll end us for today. I'm happy to take any more questions. But otherwise, I did, during break, I looked at some of your chat questions and I noticed somebody said, is the study guide, does it cover all 3 lectures? And yes, it does cover all 3 lectures. Absolutely.
I wanted to ask you about the, oh, sorry.
Go ahead. No, go ahead.
The Lantus one can be taken together with other insulins, right? But it cannot just be mixed in the same syringe.
That is correct. That is correct. You could, in theory, give the patients Lantus insulin, but you're also giving some rapid acting based on their blood glucose level, but you can't mix them in the same syringe. Yes.
Professor, what about Levemir? Can Levemir be mixed?
Levemir cannot, no. The long acting, neither of them are meant to be mixed.
Okay, so it's not just Lantus. Okay.
Yeah, it's not just Lantus. Yes. So how are we doing with that content? Okay. Everybody reasonably content?
I'm sorry, can you just repeat which ones you can actually mix? Is it just those 2 that are on the slide here?
Think in terms of the short and intermediates can be mixed. The long term cannot be mixed with either of the others.
So short and intermediate, those can be mixed.
They can be mixed. That's right.
All right, thank you.
Yes, absolutely.
And the rapid one, right?
Yeah. Yes. Thanks. Yeah.
Okay.
Rapid, short, and intermediate can be mixed, but not the long term. The long acting, I should say. All right. Very good.
Thank you.
Are we going to cover the nutrition in next lecture? Because I had some questions about that.
We're definitely going to be covering nutrition. We're going to be covering, we have a lot more to cover actually. But yes, we will be covering nutrition without a doubt. All right.
Thank you.
Okay.
Thank you.
We'll end for today and I'll see you again on Monday.
Thank you.
You're
Very
welcome.
good lecture. Thank you.
Have
You're
a
very
great
welcome.
weekend.
Thanks. I appreciate it. Okay, you too. Bye-bye.
I have a question, Betty.
Oh, yeah, sure. What's
before
up?
I just want to confirm, the regular is the clear and the NPH is the cloudy, right? Or is
That's
that
right.
Okay.
Both regular and both the immediate or the short, as well as the rapid. They are both clear.
Okay.
And then it's the intermediate that is cloudy.
Okay, that's what I.
They've basically added some proteins to the insulin to slow down its absorption, and that's what makes it longer acting.
Okay.
Okay?
Thank you.
Yes, you're welcome. Goodbye, everyone.
Thank you.
Bye-bye.